G'day, this is Lloyd again, and this continues our discussion on the glenohumeral joint, focusing on the movements that are possible at the joint and the innervation of the joint capsule itself. So what movements can we perform at the glenohumeral joint? Well, in the sagittal plane, we have extension, and extension is performed primarily by posterior fibres of deltoid, the teres major, the long head of triceps, and latissimus dorsi. Also in the sagittal plane, we have the action of flexion. And flexion is performed by the anterior fibres of deltoid, by pectoralis major, and by coracobrachialis. The long and short heads of biceps brachii will also be involved in the flexion of the glenohumeral joint. In the coronal plane, we have abduction, and abduction is performed by deltoid as the prime mover and supraspinatus as the initiator of the movement of abduction. Counteracting abduction, we have adduction. And adduction is performed by pectoralis major, by latissimus dorsi, teres major, and also a little bit by the long head of triceps brachii. And in the transverse plane, we have rotation. We have lateral rotation, or external rotation, and we have medial rotation, or internal rotation. Lateral rotation is performed by infraspinatus and teres minor, as well as the posterior fibres of deltoid, while medial rotation is performed by pectoralis major, the anterior fibres of deltoid, teres major, subscapularis, and latissimus dorsi. So there are a lot of muscles involved in moving the glenohumeral joint. So now I'm going to crowdsource a couple of questions to do with the movements of the glenohumeral joint. So for each movement of the glenohumeral joint, where would you expect the muscles that produce the movement to be relative to the joint? And then adding to this, what orientation would you expect the muscle fibres to be in? Would you expect them to be in the transverse plane? Would you expect them to be running superiorly to inferiorly? Things like that. And the purpose of this is to apply your reasoning and logic skills to figure out where, if you were designing a body, you would position the muscles in order to produce the movements that you want it to produce. So we'll just focus a little bit on the rotator cuff muscles that we've looked at in a previous video. So the rotator cuff muscles are dynamic ligaments that hold the head of the humerus into the glenoid fossa. And there's four muscles in this group: supraspinatus, infraspinatus, teres minor, and subscapularis. And together they are helping to stabilize the glenohumeral joint and prevent its dislocation by balancing out the rotary forces. So supraspinatus is passing superior to the glenohumeral joint, so we'll be involved in abduction. Infraspinatus and teres minor are passing posterior to the glenohumeral joint, so we'll be lateral rotators, while subscapularis is passing anterior to the joint, and so we'll medially rotate the glenohumeral joint. So again, all of these rotary movements are being balanced out to hold that head of the humerus against the glenoid fossa. So deltoid, this large muscle overlying the glenohumeral joint, is often considered to be the prime mover of abduction. However, if we've got our upper limb passive by our side, the force of deltoid is pulling directly upwards, which will cause the head of the humerus to clash against the acromion process. and as well as potentially dislocating or damaging the glenohumeral joint, there wouldn't actually be any movement at the joint. So we need a muscle to pull on a more oblique or transverse plane in order to be able to initiate the action. And this is where supraspinatus comes into play. So supraspinatus is in the supraspinatus fossa, passes superior to the glenohumeral joint and inserts into the greater tubercle of the humerus. And supraspinatus's line of pull is on an oblique angle almost in the transverse plane. So it causes the first 10 degrees of abduction before deltoid can take over and lift the humerus up to complete the action of abduction. So supraspinatus initiates, and deltoid completes abduction. Now the glenohumeral joint is also receiving innervation. And if we follow Hilton's law, which states that the nerve that supplies the muscles acting at a joint also supplies that joint and the skin over the joint, we can say that any nerve that is innervating any muscle that is acting at the glenohumeral joint is also going to innervate the joint itself. So if you go back a few slides and have a look at how many muscles are actually involved at the glenohumeral joint, it will give you an idea of how complex the innervation of the glenohumeral joint is. So the structures that are being innervated are the joint capsule and the ligaments. They're going to require afferent nerve fibres to detect any pain or stretch. But there's also blood vessels supplying the joint capsule and the ligaments and the muscles. And these blood vessels will have smooth muscles in their walls and so will require visceral efferent nerve fibres as well. So the nerve fibre types that we have are general somatic afferent for pain, stretch, that type of thing, and general visceral efferent for vasoconstriction and vasodilation. And the major nerves that will be carrying these nerve fibre types are numerous. So we have the suprascapular nerve, which is also supplying supraspinatus and infraspinatus, the axillary nerve, which is supplying deltoid and teres minor, the lateral pectoral nerve, which is supplying the pectoralis major and minor, as well as multiple other nerves supplying the muscles around the glenohumeral joint. So the musculocutaneous nerve, the radial nerve, the subscapular nerves, all of these will be contributing. And to find out exactly which nerves are contributing and the structures that make up the glenohumeral joint and the movements that are possible and the muscles producing these movements, you can consult the prescribed textbook. There's diagrams in your study guide which will help you with this topic, as well as the principles booklet. And you can find me, Dr. Lloyd White, on the LMS discussion forums where we can discuss this further. You can also discuss this further with your practical facilitators. So thanks for taking part. For now, goodbye.